physical examination on the baby, remember the patient is sick. They're not in hospital for fun. They're there because they're not doing well. And then maybe the baby is also unwell, and constantly there are people milling around this baby, increases anxiety. The hospital already is you're already overwhelmed by being in that environment. Sorry. But now there's also the added stress of having to deal with students. Yes, it's a learning institution, it's a training. We used to say, if you come to Moi teaching and referral, you have already given permission for us to learn from you. So, yeah, but is it always so? Maybe not. Yeah, so that's why we want to go into simulation and skills labs, utilize the skills labs fully. Yes, thank you. So the skills lab is meant to be a controlled environment. Looking at all these mannequins, money has gone into bringing them here. And we want to take care of them for as long as possible so that it gives us many years of service and many students learn through it. But when we keep it as an open space, anyone can come in, leave with an item, then we are also, not taking care of a skills lab the right way, and you're also not taking care of our investment in the right way. It is an environment where the student is supposed to do repetitive practice, because this is a safe environment. I can learn again and again until I perfect the skill of cannulation. I learned cannulation on a patient, and that was so many after, you put a cannula, then you've gone through and through, then imefura, and then you look for a story to give the patient that maybe it is their blood that has something. Then you tell them, let me try on the other side. And, over and over until you perfect the skill, but that was not the best way to learn. And then skill mastery, we keep improving on the techniques, or the students keep improving on their technique of, clinical procedures. So then we need to differentiate skills. Skills, there's repetition. Skills, there is, skill mastery. When it comes to simulation, we are putting together the skills mastery with critical thinking, decision making. Okay? Because when you get a student into a simulation space, you're trying to give them a scenario that is as realistic as possible. You're giving them maybe a child who has come in with history of diarrhea for the past 3 days, and on examination they have thready pulses and maybe they're not breathing. What are they going to do? There is the mastery of the skill of very quickly assessing the patient and knowing what to do. Then there's the aspect of critically thinking in terms of how long am I taking? If this was a real patient and I'm taking time to, fix my line or call for help, should they flatline? So they're putting all this together in this simulation space and improving on their critical thinking and decision making. What they would ideally do in a real patient environment. Now they're doing it in a controlled environment so that they learn. And as faculty also, we need to go through the training of how do we run simulation. It is not meant to stress the student. It is meant to help them learn and improve on their critical thinking and decision-making skills. So here in simulation, we want to replicate a clinical scenario as realistically as possible. And as faculty, you give a clinical scenario, a real clinical scenario, only that it's in a self-controlled environment. Then you're using mannequins, and you can also use a standardized patient. It doesn't only have to be the high fidelity mannequin. I can use a standardized patient or an actor who I have given, the scenario to. You will come in with your baby, or you will come in yourself. You come in with abdominal pain in the right upper quadrant or whichever pain. And after 1 minute, the pain keeps increasing, because what you want your student to pick out is the cues of, is the student able to pick out that the patient is deteriorating, and what are they doing about it? So not only mannequins, you can use even the basic mannequins to run clinical scenarios, and you can also use the advanced high fidelity mannequins to run clinical scenarios. And the other thing is, your focus when it comes to simulation is critical thinking. Critical thinking is a very important component in the hospital. And I know you've possibly gone into scenarios where you go into the ward, you as an individual, you're seeing this patient is not doing well, but for some reason, everyone seems very comfortable around the patient, and you're wondering, am I seeing my own things, or am I just being overly, a nurse? No. They usually those are nurses, and then wewe unajiona wewe ni, what do you call, nightingale. You're a nightingale, typical nurse. No, it's about the care, because in your critical thinking, you're able to see this patient is not doing well. When you look at their vitals, you're like, apana, there is something going wrong. Critical thinking. So you want to get your students into that space of being able to think through scenarios and implementing a plan of care. And also that is where the nursing process will come in. Critical thinking, then you put in the nursing process of what then do they do. So why simulation and skills lab matter? Safety. And this is safety both for the student and overall safety to the patient. The patient they will handle in the later days, learning from their mistake. So it's not supposed to be punitive. Simulation is not supposed to be punitive. It's supposed to be educative. So when they miss an aspect, maybe there are different methodologies of running a simulation. You can do the start and stop. You give them a scenario, you watch what they're doing. If you see they're veering off, stop them. Then you go through, talk about it, then you allow them again. But now for the advanced levels, like maybe fourth year students, they have already done the start and stop in year 1 and year 2. Now they're supposed to put it all together and know what to do. So you allow them to run through the scenario, start to finish. Then you have a debrief. You have a discussion on, this was the scenario, tell me about it. How did it go? If maybe you identified a gap in between, you talk about it rather than giving feedback. You did not. This one is more of walk me through your experience during the scenario, and studies have shown that it's actually better. If you give me a scenario for CPR, I run the scenario for the maybe 10 minutes. 10 minutes is really long, but you run the scenario for 10 minutes, and all through you are timing me and annotating, or you are writing as you are looking at what I was doing. Then after it, you come back and talk about, okay, let's talk about the scenario. The patient came in like this. What did you do first? What was your priority? Maybe I did not know how to do the C and E when doing my bag and valve. So we discuss, how do we get the seal correctly? How do you position the patient? So, those are learning gaps, as opposed, you need to go back and review your books on how to do CPR. You need to, go back and review on algorithm of, that one, you're sending them back to the books rather than addressing the issue there and then. So you debrief with them. But that also requires you as faculty, you as a skills coordinator, to be well informed, very well informed, for you to have that discussion with them. What does it do? And this is the ultimate goal of training, is to have a confident student. A confident student, a student can only be confident if they're competent. Yeah? They know how to identify a collapsed patient. They know what to do when the patient collapses. They'll not do what we did those years back of disappearing to the CSSD when you hear there's a resuscitation. And we did that for a couple of years, because I just see people on top of the patient, and someone is doing something, and someone is doing something, and someone is running, and you're wondering, maybe I should also be running to do something. Get a glucometer, or maybe it's the sugars, or maybe I go for hydrocortisone, but why am I coming with hydrocortisone? Rational, you're just running because people are running somewhere. So, but now, if your student knows, this is how, if a patient collapses, this is what you do. Very fast. So, go and stimulate. Check pulse. Is there breathing? No breathing. Within a minute or a few seconds. Shout for help and start your CPR. And they know where to place their hand, because they have done it on the mannequin so well. You have done the skills checkout. You've run simulations with them. When they see the patient collapse, they will know what to do. They will call for help and not run, but go and help the patient. Confidence. So it builds confidence. Competence, confidence, our patients are safe. So what are the components? We've talked about it. Repeated practice, scenarios, debriefing rather than feedback, and then you go into your OSCEs now. After you're confident about your students' experience in the skills lab, now you do the assessment. But the assessment is meant, as much as it's meant to, score them, it's also meant to just, give them a pass. This skill, you're good at it, you can handle the patient. So then what is the role of clinical instructors? And not just that, even faculty, because even faculty come to the skills labs. When you train on something, you want them to have a hands-on experience, you come to the skills lab. You want them to have a hands-on experience on how to provide emergency care. You want to create a scenario for them. So then, one is to facilitate practice, learning experience, effective debriefing. Remember, you have to be very clear from the beginning what your objective for that particular scenario or that particular session is. Then you have a constructive debrief session with the students. Then the biggest thing is we want to model a professional behavior in the student nurses. We don't want them to go to to graduate and go to the hospitals without having that professionalism in them, because the simulation experience itself starts from communication skills. How do they communicate to the patient? And I will encourage us to give our mannequins names. So they call them by name, like Hal, Marius, Winnie, whoever. They call them by name so that when they go to the patients, real patients, they will refer to the patient by name. Sio, umeamkaje leo? Who are you talking to? Mr. So-and-so, how was your night? Good morning. How was your night? It's usually one of the hardest things I've seen with students, because I have been in clinical placement from, AMREF, but I end up, do I call colliding? No, let me not call it that, but almost disagreeing with a student from another university, because they come in and nimekuletea dawa. Mwe ni nani? Umeletea nani? You don't have even a treatment sheet. Umeambiwa peleka bed 15. What if 17 exchanged with 15? And you're not aware. You'll give the wrong person the drug. So it comes down to the basics of it. Communication. Good morning, sir. My name is so-and-so. What's your name? How was your night? That in itself makes the patient feel seen. And as clinical instructors, when you go for that assessment, be the first one to say good morning to the patient. Then the student will see that it's important for you to greet the patient. So we model professional behavior. So best thing when you're utilizing the skills lab, the simulation space, is to be prepared. And I think I talked to Prof some time back. We're trying to find a way to link your clinical instructors and faculty for methodology training, because not everyone can run a skills session. Not everyone can run a scenario. You have to be very clear, what am I going to teach today, and what are my expected outcomes? What's the goal for this skill today? Yes, we are going to give IMs today, but it has to be very clear what's the goal for this particular session and why is it so important. And you come up with the objectives and metrics for which you will measure yourself as you're measuring your students on the outcome of the skills sessions. So you have to be prepared. Plan your lesson very well so that you do not have 15, 20 students around you. Will they be learning really? No. Most of them will be like this. Kwa simu, we know the generation we are trying to teach. So no, you're talking, wako hapa. On TikTok, if you ask them a question, they're also wondering, yeah? Like you asked, okay, what are we talking about? So, make it small, short, practical. 6, 7 students, run an IM. You've already done drug administration in class. When you come to the skills, is now skills mastery. So 5, 6 students, show me. During our time, we used to do the I hope it's not being done now, but we'd start with oranges. Of course, we do the class sessions on drug administration. Then you come buy oranges. Then we inject the oranges instead of eating. We inject the oranges, wasting vitamin C. And then after that, the ultimate experience of drug administration was injecting each other. Yes. Anyone from University of Eastern Africa, Baraton here? You inject each other. And the aim was, if it is painful, know it is painful to the patient. So if you inject badly, if someone injects you badly, you return the favor. Hapo, malipo ni hapo. There's nothing else, but hapo, you inject me badly, I inject you badly. Yeah. So you had to master the skill in an orange. Actually, it was not nice because that was a one skill session where we were always very quiet and wondering, okay, you're anticipating, because of course it will be painful. And it was 2 cc's, not even one. 2 cc's deltoid. So nakuja prepared. You glove up the way you'd inject a patient, hand washing, you come, glove, do you drag in, remove the air, do your pinch, inject, release, HEVO, then I give you health education. So you'd choose which drug are you giving me, simulated in our head. I'm giving you diclofenac or whatever drug I'm giving that can be given IM. So that was that session that we all dreaded, but I think it taught us one thing. You have felt the pain, so you need to know when you're going to inject the patient, they're feeling the same pain. So you'd better demarcate very well where you want to give the injection. You have to pull back and see that there's no blood, and then you inject. Right nowadays, I don't know, we still do that pull back, and very few people do that. Wanaenda kama mesukuma. I have seen it done. Students. Yes. Wanaweka, that patience of, shikilia, balance, pull it back a bit, then you inject. Some of them don't have that patience. So it is dunga, skuma. Nurses have mastered it. So you don't sasa I am pulling it back. Now I'm injecting. But you see, when they're watching the nurses do it, they miss that part of it was actually pulled first, then it was injected. So they must know, but I see the nurses just injecting. So that's a skill. They need to learn it here. So we need to engage our students actively and also give timely feedback and very specific to a particular skill session and a particular student. And we should not hold back on you have done it well. You did it well. You did it well. I liked the way you did 1, 2, 3, 4, 5. So you reinforce, positive reinforcement. You did it well. It encourages them as opposed to nyinyi naona mtaki kukuja skills. Nja hakuna. Amtapita mtihani mpaka mkuja skills lab. That's already fear. You're putting fear. So they will come because we need to go for 5, 6 sessions rather than I want to go to the skills to perfect my skills, to master that skill. So we need to change that kidogo. And that's entirely what I wanted to talk about. But now, this one is a bit tiny. I hope I'll be able to open it up. I thought I should bring this one in. Do we already have a skills lab policy for the students as well as for the staff? The students need to know, number one, they should not come in with food to the skills lab. They should not. Food and water, take it from wherever. When you're coming to the skills lab, it's a skills session. There's no eating. Number two, the attire, not coming in with clogs. That one you're not modeling a professional behavior in our students. I've seen some institutions, you have to be in if it's home clothes and you're coming for the skills, it has to be closed shoes. Remember, you're handling needles, so you'll be injecting things. Ikikuangukia kwa mguu, because it can. So they need to do what they would do in the hospital. This is their first hospital here. So they do it right here. And in some institutions for which resource is not an issue, and I actually agree when you're talking about the bottles and reusing, it's very important because you can't keep throwing them. Because at times what they need to do is, this is how you You start an IV, this is how you connect. And you can actually reuse, but it needs to be clear, not with a real patient. This one is simulation. Yeah. So you can reuse those ones because consumables can be very, very expensive, especially when it comes to the skills labs. So yeah, so we need to model professional behavior from here. This was just here, just a sample of a skills lab policy, just to spell out what are the objectives of the skills lab and what is the expectation. And the students need to be able to read it and signing. Signing means you've understood what is in the document. You can even make it short to a one-pager, just highlighting, the do's and don'ts in the skills lab, so that a student does not come with a felt pen, permanent marker, and starts writing on the mannequin, or they put lipstick on Risasi Ann, or they come with a pair of scissors and cut the cervix. This is money that has gone into procuring the task trainers. So they need to know, if you mishandle the task trainer, prof, it should be punitive. If it is you who cut, you will buy. So that the next person will not mishandle items that are meant to aid in training. But it has to be made very clear from the get-go that this is how we engage in the skills lab as an introduction to the skills lab. When they come in, you should not, draw on the mannequin, paint their teeth, paint their nails. Because when you put markers on any of these mannequins, it's like an indelible mark. It doesn't come out. Then if you try and scrub it, now you're spoiling the material completely. And then now you'll have a very, mannequins with marks all over. Someone has written an interesting thing or drawn a tattoo on the mannequin and doesn't look nice. So they need to know modeling professional behavior. They need to know that there's a policy which is communicated to them very clearly before they come in. Then they're able to utilize the skills lab. And I think that's where my presentation ends. But I'll also send the sample policy with prof and faculty. Just you tweak it so that you make it an Uzima document for the students to sign on them. Any questions on that before maybe we go to the mannequins? It is either you understood everything or understood nothing. It can be extremes. It can be the extremes of that. You got it, or like, what is she talking about? Yeah.
I just want to get what you have shared with us, because when you have a policy, as our students, when I had an experience of doing demonstration. Then when I turned, I found one student already amputated managing.
Must be this one.
Walking around with it, and I was like, what are you doing with that? So when we have that policy,
Yeah.
it really has to then there's just
Yeah.
doing some
Yeah.
when you try to
Mm.
and they were doing like and I was like, what's really wrong with you?
Yeah.
And there was this also the one for pulsation.
Mm.
They went inside and removed the baby, and when we were doing no school,
Mm.
it was not easy to fetch the
Mm.
lad
Mm.
and the
Mm. Mm.
so this policy.
Yeah.
But if anybody listens or misrepresents and destroys any of the money,
Yeah.
they should pay.
Yeah. And it should be made very clear so that they don't say, but you're bringing this along the way. No, you read the policy. We confirmed that you've understood the policy. You signed. The fact that you signed, you're an adult above 18 years, means you can read and write and understand. It means you understood that you should not mishandle because these are meant to aid your learning. Yeah. So modeling professional behavior. It has to start from clearly stipulated policies of how, interactions in the skills lab. And then also, whoever will be in charge of the skills lab, there should be a schedule. And that will come with timetabling. The faculty know at lesson this, I'll need to use the skills lab. So then with that scheduling, it's easy to operate in the skills lab. So, I'm in the skills lab in the morning for about maybe 1 hour, 2 hours. Then someone else comes in and another person, and it's very clearly scheduled so that you say, okay, but I wanted to use that, but I booked before you, but I have many students, but my students are senior. So it avoids that one. So it's very clearly programmed. And then there's cohesion. And it's easy to work with the skills lab. Yes. So thank you so much for that, for your points. Yes, Celine.
Canada is the numbers that you have, and for a 2 hour session. I think what you brought up is the numbers that we can have. You could see a situation where you're actually trying to demonstrate something, and the students are meaning, but because of the time constraint and the number and you want to cover that, then you want to put it in your head that everybody has seen. But in the real sense, behind you, you know very well there are some who are behind you who are
they're drawing things and walking around with mannequins.
Doing what you said.
Yeah.
So I think it will call for us to really highlight in who, what, when, and make sure that each and every student is taken care of. That we don't miss them.
And thank you for that. And that is where also the clinical instructors come in, because at times maybe you're in session, or if it's a physical assessment, health assessment class, physical assessment class, you can choose to be faculty and 2 clinical instructors for this particular 2 hours, so that you run the session for all the students within this time, and you're sure at least each person has seen what is going on. Usually the ratio is 1 to 5, but of course we can stretch it, being our low middle income resource countries. You can stretch it to about 10, because 10 can. So 10 on this one, 10 on that one. You can also use this for physical examination, 10 on this one, and you have 3 faculty. You can do your session and then stand back and get, return demos and questions, because in group of 10s, they're able to ask you questions. If there are 50, someone will ask a question that you have addressed because the person did not see. They are craning their neck to see what is going on. Then they'll ask their friends, teacher alisema pafu, the way broken telephone, whatever the person will be told is not exactly what you said. And the third person is even more disadvantaged. Sikusikia but alisema kitu kama, that's how the conversation goes. So the whole learning experience is lost in it. Thank you, Celine. Clinical instructors, ask me questions. Clinical instructors, you're the skills instructors, by the way. Because when you go to the clinicals, you're essentially looking at what we taught you in the skills lab. Is it what you're doing here? Clinical instructors, questions? No questions? No questions? Okay. So I guess maybe we can go to mannequin by mannequin. We get to talk about them bit by bit, or we can go into groups. So how would you run it? Okay. What I'm comfortable is, one, let's run on care of the mannequins first. We do care of the mannequins, and we've already alluded to one of them. And an example of how not to care for the mannequin is here. the don'ts. The don'ts. So I think something went wrong here, but I'll try and find a way to put it back. So number 1, we've said let us not write on the mannequins, because it will get stuck. It will not come out. It's like an indelible mark. It won't come out. Let us after a session. I remember I was told don't dwell on the don't because that is what people will remember as do's. So let's go to the do's. So how do we care for our mannequins? One, as much as possible for the task trainers, they should be retained within their packages. An example, you see this on the limbs and things. It has its own package and it's for the prompt flex. So we maintain the packaging until we need to use them. Yeah, because then what this helps with, the students will not come writing on this while you're busy teaching on CPR because it's available. I can do whatever I want to do with it. But if it's in its packaging and safely kept, it is very hard for a student to go and look for it to start, manipulating it when they're doing another session. So let's keep them for the task trainers, we call them. So we usually have task trainers, then we have mannequins, then you have simulators. So mannequin simulators, more or less the same thing. But these ones are task trainer, because it is training on the task of delivery, labor and delivery, the task. This one is also a task trainer for the breast. It's also a task trainer because the task it's training on is on breast examination. It's a task. And also the other thing you're going to train on is on communication skills. So we will have to learn to be as imaginative as possible when you're in the skills lab. So you tell a student, this is Anne, who's coming to the clinic, is maybe a 16, 17-year-old, and would like to be trained on self-breast examination. Then you step back. They'll need to refer to this thing as Anne. Good morning, Anne. How are you doing? Imaginative. So, yes. So, the whole session of informed consent, ask for permission. Don't think that you're asking a still thing for permission. Imagine this is Anne. We are asking for permission, and I'd like to walk you through the concept of self-breast examination. You're assessing them. They will tell Anne the importance of examining their breast, when they should do their breast examination, the old position of, like this and like this in front of the mirror. They actually do it with this. It's training on the task, but it's also bringing in the component of communication skills, which you're also assessing. So task trainers. Then we have the simulators or the mannequins. Mannequins with MANIKINS, not mannequin. Mannequin is the ones zinavalishwa nguo kwa nini, the ones that model clothes. Mannequin, yes, display. So these are simulators. So we have low fidelity, mid fidelity, and high fidelity. Yeah. So when you're talking of fidelity, what you're thinking about is how able is it to elicit lifelike physiologic responses. Low fidelity, close to zero, because it's just a basic doll. That's why it's also called a nursing doll. Yeah. Then we have mid fidelity. It can replicate things like pulses, but it is manually done. So they usually come with a squeeze bulb. So when you do the squeeze bulb, you will be the pulse. So it can either be so fast or very slow and thready. Then the student will be able to feel the pulse. So that is one of a physiologic response, pulses. There are also mid-fidelity that have also incorporated CPR metrics, meaning you can connect the mannequin to a Bluetooth through an app or a gadget. And then when the student is doing the CPR, you're able to see on the tablet, are they doing it the right way? Are they, doing the compressions and not allowing for a chest recoil, which you will get from the metrics on your tablet? Or are they not able to get air into the lungs? So, the C and E grip, are they able to get the right air ventilation into the mannequins or Sylvia's chest or airway? Mid fidelity. High fidelity, you will be able to elicit physiological responses automatically. So you set on your mannequin, I want respirates of 15, maybe the breathing rhythm, you want to give it chain stocks, maybe you put crackles in the chest. So as the student goes to the mannequin, one of the things with the high fidelity is that they have, there's the ability for you faculty to be the voice of the mannequin, or you use the pre-programmed voices or the pre-programmed speech of the mannequin. So how will that help you? Communication skills. So the student will go, hi Sylvia, how are you? Faculty, you will respond in another room, I'm not feeling too good. The student will hear it from the mannequin. Or when they ask, how are you Sylvia? You use the pre-programmed speeches in the software of the mannequin. When they go and do a physical examination, they do auscultation, they will hear what you have said. You had said crackles. So they will hear the crackles. So then you'll ask them, by the way, what did you auscultate? You already know there are crackles, but you want to know what did the student hear? And is it in the upper airway, I mean on the upper lobes or the lower lobes? Or is it a silent chest? No. There are some mannequins that you can, for the advanced level of training, like higher diploma critical care. I think, I'm not very clear about the curriculum, but they are able to do a little bit more advanced care with the mannequins or with the actual patients. So you can put in the mannequin a pneumothorax and see if they will actually realize that there's only chest rise on one side and not the whole chest. So you see, you're incorporating critical thinking without telling them, I have set pneumothorax. No. You control the parameters of the mannequins. High fidelity. There are very high fidelity mannequins that can also incorporate the whole concept of neurological exam, head to toe, everything. So as they look at the pupils, consensual, we call it a response to light, they actually do that. You can change one side of the mannequin, you can simulate head injury, and you see if the student will actually pick, these are signs of, some raised intracranial pressure, because you can see it in the pupils. So you'll set the mannequin to be a patient with head injury, then you see what the students are able to pick out. Critical thinking, clinical reasoning, high fidelity mannequin. The mannequins that will even respond to pain stimulus. So if you rub the sternum, it will raise its hand because it's been set to do that. There are sensors within the mannequin that if you rub the sternum painful enough, the way we do in a real patient, if it is, what do you call it? What do you call that response? The word has disappeared. So for you to grade it as a response to pain, they have to locate the pain. But if the patient just does this, see, that is not response to pain. They need to be able to locate the pain. So that's what we do with patients. If you rub the sternum, the patient should be able to do this. Now that one they've responded to pain. When you're doing your AVPU, yes, they've responded to pain. But if you rub the sternum and all they do is a bit of movement, that is still a U. That's an unconscious patient because they cannot pick out where the pain is and remove the origin of pain. So there are mannequins that are able to train on that. So you'll put it to respond appropriate, that's the word I was looking for, appropriate response to pain. So you'll try and simulate, do a sternal rub on the mannequin, and the mannequin will do that. It will raise its hand, okay? And you can also put decorticate, decerebrate, all that on the mannequins. But those are very high level mannequins. So care of the mannequins. You put it in the boxes. Once you're done with the mannequin, what you do is just wipe it down with a soft cloth. And if you're using maybe KY, jelly, the lubricants, you don't use a scrub, no. You just wipe it down with water and liquid soap, not bar soap. Bar soap will cake. It will go and cake on the mannequin. So you just use liquid soap. the person in charge of skills lab, or maybe you choose a student. And imagine we can still allocate roles to the students. I don't know why we've stopped, because the students will say, si kazi nikuja kufanya tafanya. So you liquid, water, soft cloth goes. Just wipe down the mannequin, air dry, and then you put it back in its place. I think what also is going to be put here, I'm sure, is some storage areas for the task trainers, so that we keep them away from the students, from the reach of the students. What else about care of the mannequin? We will need to have a conversation around biomed, because at the point where you'll get the higher fidelity mannequins, they'll need to have 6 months maintenance, twice yearly, biomedical maintenance, because remember they have movable parts that some need to be oiled. Yeah, so you need to have a biomed, or maybe train one of the skills instructors to just be able to, lubricate the movable joints so that we don't get rusted. Remember, they're not human beings, they are models, and they have metal. So you have to keep the metal lubricated so that you do not get rusts, and then the mannequin stops functioning. Then the other mannequin that also needs maintenance is this one, the CLA1B. When it came, it had already been primed from the manufacturer. They did the silicone spray in the joints, the movable area. So it has to be done every 6 months. And the spray is in its, the silicone spray is in its, the CLA box, the one it came with. It came with its own consumables. So you just spray kidogo tu, and then you rotate the joints so that you keep the silicone, it doesn't crack. This is a mannequin that will serve Uzima for the next 15 years before you need to change anything, unless someone disappears with the eye, or someone removes the arm or the genitalia and goes with it. But it is something that you will use for 15 years minimum. And every part of this mannequin is replaceable, from the eyes to the airway to the trachea system. I got one in Siaya KMTC that had been donated many, many years back, but all it needed was just maintenance, spraying and a bit of Vaseline. That Vaseline we use, Vaseline. So you use Vaseline on this one for, the lips, to keep the silicone from cracking. What else about the mannequins? I think we've basically talked about it. Of course, keep it away from direct sunlight. So I'm hoping at some point you're going to put your curtains, because sun, silicone, plastic, cracking. So you'd want to keep them safe from direct sunlight. For silicone, whenever you're using the mannequin that has silicone, an example of this, make sure you put enough lubricant. Okay, it is silicone, it will stretch, yes, but when you use enough lubricant, like would a birth canal, you will use it for a very long time. It will not tear at all. So the trick is in using enough lubricant when you're using it for training. So it's both for the cervix and for my baby, for this baby here. So the baby has a bag. You'll notice anakaa ameparara. So this one, for the for the silicone-based task trainers, it comes with talcum powder. So the talcum powder is to keep it from being sticky. So rubber, joto, sticky. So what you do after you've wiped it down and it is well dry, you put the talcum on it so that it doesn't become that sticky, annoying feeling. Stops it from doing that. The other thing, if you cannot hold a baby like this, please don't hold the mannequin like that, because it goes to care. If you cannot hold a baby, a real baby, can you walk with the baby like this? No, you cannot. So don't hold the mannequin like that. Hold it the way you'd hold a baby. A baby, you'll want to bundle the baby up like this. Then you'll want to hold the legs. Asianguke, support the head. Hold the mannequin like that. Sounds funny, but actually yes. You'll use it for a very long time. You'll not have issues of the joint imeng'oka, imeenda, mguu mtu ameenda kiklap nayo mkono, ameng'oa ameenda nayo. So even the students need to know, when they're holding this baby, this is how you hold it. I usually go for exhibitions, and I think the people think I am bordering madness maybe, because this is how I hold my mannequins when I'm doing a demo. the way I would hold a real baby, like that. Yeah, and put it on the side if I want him to stay there. Other than the way it was in the box. So we have to take care of our mannequins. Same with the adults. If it is folding the limbs, maybe you want to do catheterization, how do you advise, like if it's a female, how do we advise the ladies to sit when you want to do your catheterization? Do they do this? No. So don't attempt to do that with the mannequin, because the joints are meant to articulate the way our joints articulate. So there's that, there's this, there's folding and stretching. But when you attempt to do a weird maneuver that a human being cannot do, it will break, because it is not built to do those articulations. They're actually as realistic as we are, as well as the head. Yeah, but the head might not do the whole 360, because still remember, it is a simulator. It is a mannequin, not a human being. Anything else? So any mannequin that comes with a gadget, the gadget, at the point maybe you'll have the bedside cabinets and a completely lockable room, then you can keep it with the mannequin. Because then, or the skills person in charge of the skills lab, manager in charge of the skills lab. And I would actually recommend that you establish that kind of a team, a skills team, to run the skills lab, because then someone is responsible. But if there's no one responsible, I will come and pick and go and not tell anyone, and even forget I picked and ask, no newborn Anna ako wapi? Nilimwona mwisho. You know, I don't remember. I didn't pick. I don't remember. You saw it. No, me, I didn't pick it. No. There should be a very clear checkout through the skills lab manager that maybe for the class session, they've taken the female pelvis and it's so and so who has picked. And when they return, ameandika, nimerudisha. Then you will have the skills for a very long time to come, and there'll not be losses, because then the students will not, who even knows? So I'll just pick this baby and disappear with it. And this thing is expensive. Should I tell you how much it is, so that you know Uzima has put money in buying this, and I'm feeling pain seeing this one like this. This is millions of shillings just to buy this one only. So let's teach our students to be kind to the institution by, utilizing the items properly. Other than that, I think then the policy, of course, have all the students, nursing students, or anyone who uses the skills lab to sign on the policy that they clearly understand. They do not come in with food and drink. They do not come in with a permanent marker. Actually, they should only have a piece of paper and a pencil. That is if they really need to come and write anything, because it's not class, it is a skills session. So no, they're not coming to write notes here, no. Because then now there'll be that differentiation. A skills lab, it is only skills, no pen, no paper, nothing, no markers, no biros. Then, yeah, we'll be able to maintain our skills lab longer. Maybe you can take a 5 minutes break as I try to fix this, and then I put the art mat as well. Then we'll start with the bathing simulator, unless there's any question.
Yes.
Yes.
As right concern,
Very.
and we have the going program,
Mm-hmm.
so that as I use it today, get more of us.
Yes.
And you say very rightly that we are human beings. I come check something after 2 weeks or even just 3 days, I've forgotten.
Yeah.
I'm asking the other person, and I'm very sincere that I don't know.
And you're the one who picked it.
That has happened. We have actually identified the responsible skills lab, because we have 2 skills labs.
Okay.
Yeah, you are aware, because we have even made some orders that we put there. And so, you can forget, don't worry.
No, I don't forget. There's none.
Yeah, I'm seeing that.
I'm trying to remember.
Yeah,
Okay. Okay.
And so we have 2 skills labs.
Okay.
And so we have chosen 2 people who should actually be taking the immediate care. Would you mind also training them specifically and not generally as we are doing now, so that then they have that at a time when we will do it.
That's okay. I am in agreement with that. And I'll even come with a sample Skills Lab inventory that now you can adopt as an Uzima document. So you just know, hii meisha, we need to order this, we need to order this one is still there, or so and so picked, hajarudisha tufanye aje. You know, there's also that conversation. So yes, I am very much open to that. Yes.
Maybe just to add on something, we've been talking about the students we move with these right of but it also goes our own discipline. Yeah, our own discipline. Because in as much as we're going through this, you'll find some crazy kind of person comes over and, of course, tries to dismantle everything and get it. So I think it calls for us to the reality of what we're talking about and to put it in practice so that the students emulate what exactly they are doing. Why am I talking about this? Because I've seen it before. It's like there are some characters that we don't even care what is happening about them. Either the nurse or whatever management they're having. And we enforce, we put a lot of force in the practice that is supposed to happen, which maybe is not rightful or maybe it's not appropriate as it is. So I'm just emphasizing that. When you are doing you do it with passion and of course with a lot of understanding from the bottom of us.
Yeah, true. I agree. There's usually this concept of monkey see, monkey do. Monkey, you'll not tell a monkey what to do. The monkey will do what they've seen. Not to call anyone monkeys, no. Our students, when they see we are passionate about the skills sessions, about imparting the knowledge and the care we give to the mannequins after, they'll be like, baby, let's take care of these things. It's owning the skills lab. So there used to be this policies are there to guide us. Still in the skills lab policy, if you're done with the session, unless there's an agreement that the skills assistants clear the place, then the faculty or whoever was with the students, together with the students, have to clear the skills lab. And remember, we are trying to create an environment that looks like the hospital. So if it is disorganized, there is no way you'll come to the clinical area as an instructor and ask the student, why is the patient area looking disorganized? Why is the procedure room looking disorganized? But see, we do that at the skills lab. So, kwani kuna tofauti, But if they know from huko, I've done my drug administration, I have disposed everything that needs to be disposed, I have cleared, I've put the phlebotomy arm away. In the clinical area, they'll do the same thing. Even if they find the other staff have left things all over this place, they will, instead of going to the phone, one of the things they will teach themselves, remember, modeling professional behavior. They'll come, prepare their workplace before they start the day. And it becomes so automatic for them. But they have to learn it from somewhere. Even those who are doing their masters, by the way, they would, I don't know, maybe you've interacted with this. Someone comes in, they're like, me, I'm higher level of training. I don't do basic things. But remember, the concept of nursing remains the same. Your work area has to be clean. Otherwise, hygiene issues. So get in there, prepare your workspace, start your day. And it becomes a culture. It will be passed on to the students. It becomes normalized. It stops being work. It becomes a part of the day.
I think one thing that makes me happy is that you say you're going to give us that should be our what we are doing now is an indicator that as an institution we are beginning a new culture. And the culture that we are beginning is
owned by the team sitting here. Of course, I know not all of us are sitting here, but we represent them. But this is like the cream right now. So we are starting a new culture where what we used to do will not be done. You know, you start by crawling and walking, then running. We are in those stages.
Yeah.
We have crawled enough. We have to walk. Then we will walk enough and we will run.
Yeah.
And so this team needs to know that the culture that we had earlier on is actually going away. Number one, we are having the real training, not me standing there and telling you what I think. It is the expert training from where we have got the money. And we have people who are designated for specific things. The trainer has already trained us that from today onwards, you will not come with your 50 students, your 20 students in the skills lab mara moja. You will have to plan. You are not starting today and saying, I need the students in the skills lab. And so we are starting a new culture that is going to see us through. These are actually millions. Sometimes when we demand for them, we don't know. Like I'm talking of the other order, which maybe has not reached her, and it is quite some time. I understand why it has not reached. Because actually it is millions of money. It is so much. So can we behave, take care of these things, do the right thing, the student will follow. Yesterday we were saying we are the models. If you don't model them well, then they will not follow. They are at the time when they are discovering things, isn't it? And that is why they take those things and run away. How does it happen? When the number is too bigger than the team that is there. And so we need to follow.
Yeah, thank you. Thank you. I think one thing I need to say before we take a short break is incorporating skills lab and simulation is not going to be an easy shift because it takes work. It takes work, but the work is only at the beginning. Because remember, we are training the same students. We are training year one, they move, the next cohort moves, but the content remains the same, or maybe you just amend a bit. So upper two, in the lesson planning, that is where in the initial phases, it will be a bit heavy. But once you have your folders of, after second or third class, I have a skill session, and this is how I plan it. Evo. So you already have your textbook of running your skills session. Then the skills team, also in the initial phase, getting the scheduling right. Up or two, in the initial phases, it will be heavy, it will demand work. But once you have it in place, it's just a matter of changing the dates. So, week one, class so and so, skills lab, week two, week three, HIVO. And you share that with faculty at the beginning of the term or at the beginning of the semester. So that it's everyone is clear that on week one, najua kuna midwifery skills lab, mi najua niko week 4 or week 5. Then it becomes, the culture. So it's just improving on it. But at the beginning, it will feel a bit heavy. But once you have everything in place, you're good to go. It's just amending the dates only, and that's it. Yeah. Yes.
I just wanted to add, the nursing council whole week or 2 weeks. Meaning that when the students are taught and they once again, now the timetable can be made. Not only 50 people can incorporate the 50. So every station lecturer. So now the number 50, and it usually becomes so that by the time they
Yeah.
maybe before that, then the 2 minutes then
Yeah.
the last
Yeah.
who will not even give you.
Yeah.
And as usual, I just have to wait for the
Yeah. Mm-hmm.
we have times when models
Mm.
and it's a bit of
Mm.
so I don't know. Say 6 months. Or
Mm.
maybe let's get a situation whereby of course you cannot say our students
Mm.
are
Mm.
very and
Mm.
knowledge. And in the process to despite us
Mm.
totally much intelligence
Yeah. Yeah.
inaona kama
Yeah.
how it can be done.
Mm.
Solution
Mm.
then model ilikuwa dismantling na university
Yeah.
forever come back. And after how long have they been contacted
Okay.
so that those models
Can be put together. Okay. So the periodic maintenance ideally is supposed to be done by a biomed, institutional biomed. But what we do, our biomed comes and walks the individual through how to provide the periodic maintenance. We are onboarding our own biomed because we've been operating the biomed from the headquarters. But now we're getting our own Kenyan biomed who should be able to do his periodic visits to the clients and just get to find out, are they okay with the simulators? But then again, even before they come, you can always reach out, tell us, a particular mannequin, this is what has happened to it, what do we do? Yeah. So if I need to come down or I schedule when I'm on this side of town, I come and have a look at the mannequin, or we send the biomed, please go and visit Uzima. There's 1, 2, 3, 4, 5 that needs to be sorted out. So we've actually maintained an open communication. If there's a concern, you let us know. The problem,
that should be answered from our side.
yeah.
We have established
Yeah.
we were not there before. Actually, the first ingredient came from outside, and we did not have very close.
Yeah.
But now we have a child independent in front of us. We are going to get in touch so that you are on and off the way we have agreed, the way the demand is on the ground. On transportation, we are trying to limit this to 0. And you have heard me say we have 2 skills lab. For now, we have not equipped the other one 100%. So there may be still forced movement that we are really trying to limit. But that will stop 100%. So that our 2 skills lab managers, one is managing the main campus Uzima, the other one is managing St. Catherine's. The 2 can only communicate on some other things. They want support on each other because we all know we are one. We are going to teach that side, this side, and with good schedules. I don't think there is going to be a problem. We'll keep the company. We will be in touch, in talk throughout. The biomedical, we will still have to depend on you. But we know institutions where there are good biomedicals, if we can agree so that they are trained by you, so that then they can maintain this for us. Right now, even if I know them, I cannot go for them to come and do this because this is not what
they do not know them.
So we will get in touch with you to get to train 1 or 2 for us so that they can do it for us. On whatever we will agree. We are starting a work together that has never been there before. And so there is a light at the end of it.
I agree.
So we are here to stay.
It's really good. Thank you for that. One of the company's policies, we're still a young company. This is our 2nd year. Actually, this is the beginning of our 2nd year. I completed first year in the company in February. But so far, the clients we've worked with, we maintain an open channel. Where we are needed, we come. We just schedule ourselves. Celine almost missed. I cancelled the other one. Walikuja late, but I'm here. So you just panga. So for Uzima, it's an amazing relationship, I must say. And plus the other institutions. So we maintain an open channel. Yeah. And this none of these are basic Chinese models of you don't know where to get the eye in case someone removes the eye. These products are from manufacturers who we can call and tell them the eye, we need to replace the eye. I need a screw. I remember they sent this mannequin without the screw. Iliwekwa. I sent it. Should be in Prof's office. So we called them, told them, hey, you sent me a mannequin without the screw for the neck. So they sent. So it's open with the manufacturer. You know where the mannequin is coming from, and the part has a number, and the mannequin has a batch number. So you can easily say this particular mannequin, this university, they know they need a leg or they need a screw, and they will ship it to us. So yeah, at least that I need to say it's an advantage with Skills Education. We have presence in 7 countries. Kenya is for the African market. But we are in Germany, we're in Belgium, we're in Australia, and Belgium as well. Yes. So 7 countries, and we operate as a very small unit. Yeah. So kitu ikifanyikia mannequin, unless mtu amevunja, know that when you have to pay, you have to buy the part, but then our biomed comes and replace it. Yes. But it's an open channel communication. We maintain it as that. Walisema after 40 minutes, concentration does this? Yes. It leaves you hanging. So we can take a break as I try, see if I can put this back. Yeah. How many minutes, Celine? Yeah. I have tried to pick all the mannequins. Like we were saying, in the care of the mannequins, we ensure we put them back in the original boxes because they are labeled. So then you don't have to go, when you need to set up for a session, you're not opening all the boxes trying to get the mannequin. So I want to start with one of our very interesting simulator or task trainer that Uzima bought from us. And Uzima was the first university to buy from us. The augmented reality mat, the art mat. So Limbs and Things is an American company that makes simulators and task trainers. And they're trying to incorporate technology in the task trainers to enhance the learning. So that you are no longer saying, right occipital anterior. The student is giving you the look of, how is that fetus in the uterus? So you can actually visualize how a right occipital anterior, how the fetus is lying in the uterus. Yeah. I didn't come with my tablet, but I have my phone. Or first, anyone with a tablet or a phone, just your phones, download Limbs and Things. It's an app. Just download LandTART, ATMAT. So Limbs and Things, just type on Play Store or iPhone, you type on your Apple Store, Limbs and Things. Let me see, let me show you. This iPhone, LandT, Limbs and Things. Limbs and Things, LandTART. You can show around. Yeah, so download the app. Anyone on Android? Okay. So just download the ATMAT. Let me see. Limbs and Things. Don't put the ART. Let's remove the ART. Limbs and Things. Limb, yes, limb. Why doesn't your phone? Yours is Android. Why is it not picking? Strange. Because it should be the first thing that comes up there. Okay, let's see. Ebu try. Have we found it?
Yeah.
Limbs and Things. Go to, are you on Play Store or App Store?
No.
Go to App Store. This one. Continue. It's okay to just set up your account, Google Play. Yeah. So if for as long as you have a Google or an email address or yes, limbs and things. So download the app. Yes, this one. Yes. Let's see. Unless your phone is not compatible, but it should be there. Limbs and things. Let me see. Have you tried? It's opening. Okay. Oh, okay. What shall I start? Okay. Limbs and things. Yeah, Play Store. We look for type on search limbs and things. Limbs. Limbs with the B. Yeah, limbs with an S and then and things. Let's see if it will pick. Things. Let's search. Let's see if it will. What has it told you? Not compatible. Which one? I found it. Very strange. When you don't want to tell us it only works with iPhone, because hers was picked very fast. Let me see. Bado, it's not coming. Is it coming? No limbs and things? No limbs and things? Kwa Play Store? Imekata. Okay. Clearly they want to operate with the iOS only. I will need to find out why. Where's your
Play Store.
Yeah, Play Store.
Sorry.
You downloaded? Yes, exactly. So I'll use your phone to do the demo if it's okay. Use this on iPhone, right?
Yes.
Yeah. Ni kama inatumia iOS. Strange. No, not teach me how.
If it's Android, it will.
Android is showing it teach you anatomy. Let's go to Play Store. Where's Play Store? Here we go back. Let's look for Play Store. Here it is. Links and things.
Training by
Please check on your settings. No. She can show you. In the meantime, try and if you can download Prompt Flex. PRO limbs and things. Why are they only on iOS? They're assuming everyone has an iPhone. I think so. So let's try limbs and things. Yes. Prompt Flex. Which one? Something that looks orange? Are you seeing anything orange? Because it is. No, not really. If it's Android, no. I'll email the limbs and things. Ask them. Because it's supposed to be this. What are you saying? Prompt with the
Not this one.
with the PROMPT. Still not speaking? Okay, it's based on iOS. Very strange. Sawa. I think it's based on iOS. It should be somewhere on your phone. Yeah, so
It's giving me a lot of time, please, to
okay, it's fine. Yours in how we can get it on Play Store. Then I will do an email to Prof to advise. So this is the app that it is based on, limbs and things. So the augmented reality, it will give you products, settings, and also a user guide. In this case, we have the bathing simulator. So we go to the products, and they have a number of task trainers, like a task trainer for lumbar puncture and epidural. They have a task trainer for chest drain and needle decompression training. They have catheterization with augmented reality. So when you're teaching on catheterization and you put this augmented reality and you're able to cast it on your screen. License. Where's the guy who's operating this? We see if he can get on Play Store. Yeah, I want to see if he's able to download. Oh, if we're able to download it there, we see if it's entirely iOS, then we'll see what to do as well. Then there's catheterization, male and female. So when you're doing catheterization, when you go on augmented reality, you'll see how the bones are. You'll see the bladder. As you're inserting the catheter, the students are able to see, in a female, the way the urethra is, and in a male, how the urethra also is and how to maneuver it. Yeah. Then they also have now the prompt flex, which is what we have. So you download. I'm downloading it on your phone. So it will download this particular setting for the prompt flex, because that is what you have. It will take a bit of time. Once it's completed, you let me know, because then we will go and scan the mannequin. So basically what augmented reality does is it allows an enhanced level of learning when you're teaching on, the labor mechanism, how the fetus gets into the birth canal, how, the positioning of the head, how it comes out. That whole process, the student is able to visualize it, as opposed to just you saying, this is how the fetus gets into the birth canal, this is how they descend, this is how it turns its head, this is how you should put your hand if it is shoulder dystocia. They have an internal view of the uterus, so that when you're doing the suprapubic pressure to relieve I'm not a midwife, to relieve the anterior shoulder, when on the app, they're able to see how to do it and what exactly happens. Open. Loading. So the first one can be interactive anatomy, whereby the students by themselves, they can learn about the different positionings. So they can put their mannequin like that and then peel back the skin. Wenye wako na macho nne kama mimi wa kuona mbali. Oops, sorry. So you can see the inside, like positioning of the pelvic bone, and you're like peeling back the skin to see exactly what happens. So I can do that and do that. Then I turn my mannequin again. I want to show them the back of the mother. Then I peel back the skin. Ideally, this is how maybe, let's say that's how I've positioned the mother. But now I want to talk about maybe the spinal vertebral column. Then I just peel back the skin and you use it to teach anatomy. So midwifery, you incorporate anatomy. And then I can still move the mannequin. I can put back the skin, position, reposition that way, then peel back the skin again. So there's there's a consultant. I don't know how midwife, you call axis or something. I don't know, midwives when they are doing VE, the pelvis, the female pelvis. You want to teach them how the diameters. Mimi niliachia internship midwifery. Exactly. So you can position and then you use that interactive anatomy to train them. And the students, I'll need to find out if it can be downloaded on Android. They're able to also download the same app and also use it for learning. So as you're teaching with it, now we're incorporating technology, because we cannot separate the phone from the student. Then let's use the phone for learning. Yeah. So they download the app and they're on the same page as you are, and you learn with it. Other than keep your phones away, no. Let's use it as a part of learning. Yes, it's an augmented reality mat. Not yet. Align QR to the visible part of the mat. There we go. So now, let's look at spontaneous delivery. I wish I could cast this on the screen. But now I've put spontaneous delivery. So it will show the whole process, how the fetus gets into the birth canal, slowly by slowly, how it gets out. Okay, I wish I had a bigger screen.
They don't count it. What were you doing
Yeah?
there?
Where? What I was doing, so what you do, once you have downloaded the app, you go and scan the mat. This empty part of the mat has, you're trying to incorporate the augmented, you're like scanning, you know the way you scan a barcode? So that's exactly what you're doing. Not even the QR code. You're scanning this whole place so that it picks the serial number of the mat. Then now you can use augmented reality. Until you scan this part, even the students, they need to scan this part of the mat. Once they do that, wherever it is they go, they can use the app to learn. They don't have to be near the mannequin until the point where now they want to look at maybe the different maneuvers. What do I want to show? Let's see. Let me try with my phone. It's not scanning the mat, but let me see. Let me try and use my phone. Where is my bag? Strange. Able try and scan it yourself. You see if it will click. Don't want to move too far from it because it will lose. Maybe you can come and just have a look at it. Let me come and try. The car was refused. You can hold it. It's okay. Then then the shoulder is released. Then they restitute. Then they're able to come out. Yes. Yes. So that is where it stops because now the maneuver is over and the fetus has been. Maybe we pick what? Yeah, let's do an internal rotation. Then we do play. So it is teaching you hand placement. That's number one. So yes, it teaches you in the hand placement. Shoulder still impacted. What happens? So if you want to see what exactly happens, you just come down. Then the students learn how should they put their hand and what are they doing. So now you're able to release the anterior shoulder. You've already relieved the impaction. Then maybe let's do what? Posterior. I don't know. So as you move, it's an augmented reality. So it's teaching you hand placement. Yes.
How you? But can it show you the whole process?
No, well, it only goes up to the point where the issue has been solved. Yes. And then if you come round to this other side, now I'm seeing it from the anterior part. We can take it back again. So what you're looking at is the anterior arm. Ooh, my head. Axial traction. Shoulder still impacted. Okay. And now you relieve what you should do in getting the posterior arm grasped, extended past. Yeah, so the anterior one to come out. So it basically shows you as you're trying to pull the posterior, what is this other hand doing? Supporting the head. Once you release, you just come back and deliver the baby. Yeah. So midwives will enjoy it more. No. This one is visual. Now you faculty, you teach. Yes. So now they're visualizing it. They are seeing it. Okay, this is how I'll get the arm. Then I go back and support the head, get the baby out.
Because as you remove the posterior, this hand is supporting
the head. You don't let it fall off.
You remove the hand. It passes through the chest. And once you've done that, it will create room. Then now you go back to the two hands, deliver the anterior.
Yeah, exactly. Yes, and there's space. Yeah. So you see, it's just aiding. Yeah, we've already pulled the what do you call it? The limbs up. So this one, we'll find a way to put it back. Yeah. So you pull back the limbs,
And we have done.
and yes, and then you're able to release the baby, the fetus to come out. We'll just need to find a way to cast this on that screen, so that as you're teaching with it, all the other students are seeing what is happening. And I'm happy this screen is here. We just need to find out how to get the prompt flex on Android. I think you should try. Yeah. But after this, I'll email the representative for limbs and things. Yes. I'll just email her to ask how we can, if the system needed. Then you cast it. Yes. You do multiple display. Yes.
Like I'm going to that, especially if it is bigger.
Yeah, that there'll be a problem. Yes, there'll be a problem during deliveries. Yeah. So this one is actually just remote. What we need to clear is the system that can allow you to download the app. Once we are clear on the system that allows you to download the app, I'll communicate.
It's actually on
Play Store. Yeah. So you just download it. Yeah. You download. And then you just scan the same way. Okay. Because they have to be on the same Wi-Fi for you to do a multiple display. Yeah.
If there's a Wi-Fi,
TV na simu na laptop.
How can this be incorporated in the video that is taken?
He's asking. He can come round.
No,
So he wants to see the screen. Maybe someone can hold it this way for him.
No, you want to download it, then we'll edit it.
You want to download what?
Don't download it.
Oh, okay. 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 So you see, it's just a teaching aid. No, touch screeners are just moving from just being like a block of something to putting a bit of reality in the whole learning process. Yes.
So like you can screen connect it on the screen, do the same, and the students are seeing.
Yes, and then you can cast. If you have like there's some nini, you just cast. Yeah, the apps you're able to cast, or you do the multiple display for as long as your phone and the screen is on the same Wi-Fi. Whatever you're doing on your phone will be seen on the screen or on the tablet. Actually, the tablet is the most ideal because then it's bigger. So you as faculty, you've already scanned it. You're going around it. Maybe you're with one student doing the casting for you. Then faculty, you're teaching them the maneuvers, and especially if now you are in the what call the midwife, the maneuvers.
For different delivery.
Yes.
Depending reach or
Yes.
shoulder distortion.
Yes. So the different maneuvers, as you're talking about them, for some of us, we actually learned those maneuvers on the app. We've never really, I think the only thing I've ever done in internship was the suprapubic pressure and the macrobats to release shoulder dystocia. At least it wasn't a very big baby, so kutusumbua sana alitoka. Like kutusumbua alitoka. Because, yeah, so that's the prompt flex. One component of the ATMAT. The other component of this prompt flex, you may see it. The other component of thank you so much. The other component of this of the prompt flex is now teaching on cervical dilatation and effacement. There's actually, you are fortunate to have two different types. So you have the NASCO one that is, it has an impact, it has a head. So the only difference is in the diameters, and this one. So when you want to use it to teach on cervical dilatation, for which, remember when you are saying preparedness, this session is very clear. The objective is cervical dilatation and effacement. Your skills assistant sets up the prompt flex for you with this perineum. Okay, so this perineum is different, and I'll show you how to remove it. It's very simple. They're just clips. So you remove the clips. Who pinched it? You was wondering. So to the back also, you do the same. So you'll just get it out, sorry. Get the inside first. So I remove my pelvic rig, I remove my cervix, then I just fold this away. I get it out. Then I just remove the clip. So this one is for the basic birthing. Now, today you're teaching on cervical dilatation and effacement. So just put the clips again. Put it back. Yes, this is the perineum for cervical dilatation. Okay, I stopped being a nurse. I have long legs, long nails. I'm pinching everything. Put it back. Then you just clip it. So you've changed your perineum like that. So the cervical dilatation and effacement module comes with its own rig. Still midwife, sometimes idea. Station, descent, here. So it has its own rig and it is numbered. So there is -3, -2, -1, 0, +1, +2, +3. So that's, station is from the vagina, descent is from the abdomen. And then we have the presenting parts, difficult labor head. So we have the different cervix, and I'll take this round for you to have a feel of it. And maybe you can close your eyes and do a VE and tell us which is which. Let me remove the dynamic cervix. Centimeter ngapi? Na si exam. Remember ni skills? Tulisoma akuna, it's not punitive, it is for learning purposes. I need transitional sense dynamic, something I am looking for in particular. Investment, dynamic, anterior lip. So this is the one I was looking for. So there's one that has been written, dynamic cervix. So yes, so the dynamic cervix works with the dynamic rig, and I'll show you the dynamic rig, and I'll also tell you why we call it a dynamic rig. So this one, wacha tusambaze. Mwenye ako na tip, atuambia ameshika nini? Mwenye ako na kafinga, mwenye ako na 10 centimeters and an anterior lip. Aya, what do you think yours is? Before you read it, because it has a label. Don't read the label. Don't read the label. Yeah, what do you think? It's a 5. Okay. Midwives in the house? This one has been said to be 5. Midwives in the house? Don't read. 6. Effacement? 70, 25?
No, it's about 60.
Okay. So this one has Evo too. Let's see fetus. You're not the fetus. You're the nurse. The nurse does not go to the inside of the uterus. You're on the outside. You're on the outside. So this one has been said to be 5. You said 6, 60%. So it is 4 centimeters, 70% effacement. So I'm mbali, si ndio? 4. But where is the difference? Look at the effacement. Yes, the effacement. You can actually feel this one is thicker, and this one is thinner and it's more malleable. How about this one?
This one.
Mm.
This is full.
Come to the outside. You're in the uterus. Yes. Yes.
This one is full. Fully dilated. The cervix is well applied to the presenting part. Taken up. But it's just revealing.
An anterior lip. Read the nini. There's there's an anterior lip. So it's actually fully dilated, but then now when we'll apply the presenting part, you'll feel there's a something. Yeah, you want to do a sweep like this, Hey, that sweeping thing, yo. Where? It's not nice. Yes. That's closed. It's closed. It's entirely closed. You cannot even fit a finger. So this one is 0 centimeters and 0% effacement. So you see, this one is different from the one from the trainers that have, it's already fixed. This one you can feel, my finger cannot even go in, completely closed, and then you can feel the cervix is still complete. It's still strong. Which one? This one. More Kenya.
It's the one you're using.
Oh, it's the one we're using. Yours? One finger? 2 fingers? 1 finger? Effacement 25 or less?
Yes.
Sindio? So now, as faculty, while you're setting up your scenario, you already know what you have put. Sindio? But now the trick, I will put one of them we see. You'll close your eyes and come and tell me which one is it. So the student, the way we blindly do VEs, we don't do speculum and then VE. No. You just do your fingers. So the same thing. Close your eyes, do the VE. Have the students close their eyes, do the VE. The aim here is for them to know when I'm doing a VE on a patient, nikiingiza kidole hivi, and I can fit them like this, these are 4. If I can fit and then I can do this. And the realistic feeling of the silicone is the same as, the actual cervix. Okay. Then this one is separate. There's 1 more, 2 more, 1 more, 2. This one is what? This one is 1 because 1 centimeter, 40%. You can feel the 1 centimeter, 40%. Yeah. So you do an estimate. So we all know V is more or less of an estimate. Yeah. My finger is too big, or my finger, like me, I'll have to put 3 to be 4. Or possibly. Yeah. Okay. So now let's look at the presenting parts. So we look at all the components of the prompt flex so that when you tell the skills lab assistant set up for cervical dilatation and effacement, they know. They put the presenting part and they set up some of the cervix for you. And again, after we are done, we don't discard this makaratasi because it is meant to keep them together. So let's look at the presenting parts. This one. Tell me which one that is. This one is easy. And then this one. Who has a face? Frank face. So as a student, go in, usually say if you do a VE and the baby does what? Yeah, you stop that delivery. But how will they know how the face feels unless they've actually done it in a skills lab? For them to say, okay, when I do this, then I feel the mouth. What am I supposed to be feeling? Which is the right presenting part that can be delivered? Who has the presenting part that can be delivered? What is this? Anterior or posterior fontanelle? Yeah, that's an anterior fontanelle. So what is very obvious about an anterior fontanelle? Diamond, isn't it? So as they do their V and they fill,
They feel the diamond.
they fill the diamond. So they will tell how the baby is presenting. Someone has a completely this is posterior fontanelle, and this one, that's a brow. Yeah, that's a brow, and that one, that's bridge. So maybe the presenting parts can go around again. So the parts are landmarked in a way that the students are able to do a V and actually tell, for them to know when I do a VE and maybe it's 10 centimeters or 8 centimeters and 70% effaced, then what is the presenting part? And are the membranes intact or ruptured? Yeah. So now, sorry, we have this part. These are the difficult heads. You can make it into a difficult head. So I can put a caput, and the caput is here. You can have your caput, these ones. You can pick the different levels. I'll open them, but then we'll put them back, all of them. So you can pick one. And then I'll put one under the skin, and then you have a feel. So it just looks like a piece of meat. Yeah. Okay, so let's put one, a caput succedaneum. It's called succedaneum, yeah? Yes. So we put it here, then we put the skin over it.
Why is it?
So for those who've actually done VEs and touched a caput, touch that if it gives it, it's cushiony. Yes. You just close your eyes, do your VE, and that is what you feel. Yeah, yeah. So the prompt flex gives you that ability to set your scenarios in a very realistic manner. Okay, so we'll put one, we'll set up one, and we do a VE, and then we move to the next one. So the rig always goes like this way. This one, anytime you're fixing your rig, your pelvic ring, it goes in like that. Then you lock it in. Even this one, the same way, goes in the same way, and then you lock it. It's not supposed to be by force because it avunjika. So just slide it in, and then you secure it and lock it. Then we look for our rigs. So we have a static rig and a dynamic rig. So the dynamic rig is when you want to teach all the way from, maybe 4 or 5 centimeters all the way to full dilatation, and the different stations and descent. So this one. So you'll put your head, put your cover, and then you insert it here. So how you move it is like this. So if I put it this high, let's try and see. Just a basic head. Msaidia head. Ile akaput. Ile akaput iko. So nichukue your caput. Then when you see the inside, there's this groove. There's a groove here, and there's a groove inside. So it's a lock and key. Yeah, so it goes in. Let me get this one out. Where's my other rig? Where was the other box? Ile box ingine iko wapi? The other box. The small box. There were 2 boxes. Sorry. Sorry. What I was looking for. It's here. Let's start with this one. Wow. Thank you. So groove in. Then you fix your head with the kaput. Put it in. Sorry. Round. Let me maybe put somewhere. Now this demo of ours would be very nice because we've not lubricated, and I don't want to lubricate for now. Because the best way to remember silicone, we have to lubricate. Just the same way the birth canal is, so that we don't risk tearing the tusk trainers. Aya, someone can come do a V. Atuambie station. Midwife in the house. As we usually say, we were. We were. So the whole process. Hand washing, teach us. You're the teacher now.
Okay, before you start
Lisa.
Lisa, how are you? Welcome to your life. You know, sometimes pattern phase or first stage. Pattern, so you allow us, and you tell her to relax. Tell her the rationale you want to say, so then once she has been told, explained to the procedure, then I go and do that. Yes, I wash my hands, making sure that my tray, my trolley, is with me with all the analysis. I want to check. Else you can go there and get that expired. So, check on it. Expired. Then you arrange your trolley, the suction, the lotion, then you have the receiver. You begin to feel that movement, very minimal movement, and okay, and you save on time, yeah, because you don't want this movement to be in this position for too long. So once I've done that, I've washed my hands, my trolley is with me here, and I have my gloves sterile, because when you have to do a vaginal examination, in the vaginal pack we have a bowl with 5 cotton swabs and disinfectant, antiseptic, which is not corrosive to the mucous membrane. So once you've done that, you need to have an assistant, if possible, for you to open the pack. And if possible, once they have opened the pack, they'll be there to assist you. You can always, and as you're doing the vaginal examination, please engage the mother, talk to her. Don't just be quiet down there. Yeah, keep on engaging the mother and talking, complimenting. And everything you do. Oh. Oh, that was so random. So once you've done that, you take your swabs. They are 5 in number. You are having a sterile glove already. You have gloved yourself. Your tray is open. Then you tell the client, before you even start doing anything, let the client know that you're about to do it. That now you tell her to position herself. That time you use your assistant who is with you, okay? And she will assist the client to do that. Once you've done that, you have your bowl, pour in the antiseptic, and you pick one at a time. Like, I don't know, let me just stand here. You pick one at a time, because this is the hand that will go in. You drop it, and the left hand, making sure you don't non-touch. Non-touch technique. You do the farthest. You clean the farthest, like that, and you drop. Again, you pick, you drop, or clean again, and you drop. As you go, you clean that way until you, then the last bowl, you will open the upper lip, then you clean once. Then when you're about to go in, tell the client that now I want to insert my 2 fingers just to ascertain the level of dilatation. So as you talk to the client, she's already aware of what you want to do. And every time you do a procedure, give the rationale. Why am I doing it? So that she cooperates. What you need is maximum cooperation, because there's some women, you try to insert the fingers, they'll jump. They will even contaminate you by maybe touching on your gloved finger. So as you go in first, you go deeper. You want to do what? Find out where the cervix is, okay? You go down completely and you look at the cervical consistency, integrity, and also the taking up and the percentage. How much has it gone up and how much is the dilatation? And if the head is, the mother is fully dilated again, you might be able now to ascertain at what position is the head or whatever the presenting part. Okay? So as you go in, if you have an assistant, they can engage the client, or meanwhile, you can also engage the client, because many a times we find ourselves alone. So you engage the client, and as you go in, you go further. First, what you want to ascertain, the pelvimetry. How is the pelvis? Is it adequate? Because there are some landmarks that you must feel. First one, while you go deeper, you want to tip the promontory of sacrum, which actually, if you tip it, it's obvious that that pelvis has an issue. Then you go around, check on the ischial spines. They should not be sharp, but they should be blunt. If you feel they are sharp, it's also telling you that that pelvis is inadequate. But whereas you find that the head has already passed through the brim and is already in the pelvic cavity, we know the measurements. The brim has 11 centimeters and the pelvic cavity has 12 centimeters all round. And the outlet is how many centimeters? The midwives in the house? 13. Good. So once you've ascertained all that, everything is fine. Now you go to the presenting part. You want to feel what is presenting. Is it the head or is it whatever? Meanwhile, you'll have also known through palpation. Okay? So you go in. You want to feel what is there. Because this one, there's already a caput. You may not feel those landmarks, but you'll feel a caput, and you want to go around it to see if the cervix is fully dilated, meaning the mother is already in second stage. So you tell the mother that sasa tunatumia Kiswahili, njia ya mtoto imefunguka, sasa uchungu hiki, and you also look at the station. Where is the head? Is it at station 0? Station 0 means you can just, like this one is at station 0. I'm just feeling the head here. Though it's a caput, you know, a caput can also cheat you. That is the head. So that's why you have to take your fingers all around to be sure that how much is the caput. Yeah, because you can start telling the mother, sukuma, sukuma, and nothing. Meaning the anterior lip of the cervix sometimes is always not opening up completely. So if there's still anterior lip, let the mother lie on her left lateral position, and pain management, encourage her to breathe in and out and all that. Because, so that's it.
Midwifery class. Very fast. And you say all these things you're saying, you can use the simulators. You can put an anterior lip.
Yeah.
Have the students feel how an anterior lip.
There was one we had here.
Yes, it is. I think someone has it. It's in the box.
There was one which and usually after the.
I think someone has it somewhere. Does someone have any cervix? Yes, that one. That's the one. Thank you. And a caput.
Yeah. So this once you usually this anterior lip, this is where most midwives miss. When you do your vaginal examination and you don't feel for it, your hand should go all around, making sure there's no cervix you can feel. But sometimes, because mothers tend to start pushing early, before the dilatation, they will be edematous. When they are, become edematous, again they reduce the diameters. So this is the time you tell the mother to lie on the sides. But sometimes when they have those expulsive contractions, when you will be now conducting that delivery as a midwife, ensure you support the perineum. As the head is coming out, you flex that head because you want to try and avoid the cervical tear. You flex the cervical head so that it gives a little room for the head of the baby to pass. Once the head is out, there's what we call a wait for the restitution, the external rotation. It will be obvious either right or left, but as a midwife you'll be able to see where the head is going, so that as you teach students, let them not just start pulling the baby, because that's the mechanism of labor. Actually, labor, we should not even be struggling as midwives. We should just be waiting to receive the baby. But in circumstances whereby you see that there's a perineum that requires support, there's a likelihood of it tearing, then you will always have to support and flex. Flexing the head is just trying to avoid the perineal tear. We'd rather have an episiotomy, a clean cut, which is easier to stitch than a ragged one. We're also trying to avoid those bad tears, because when they have tears that go up to the anal mucosa, or sometimes it goes beyond until the anal sphincter, you can imagine, we'll be subjecting that woman to what? Fecal incontinence. And that communication would really be sad. So that's what we do. And once you've delivered this cervix, mostly, now when you go in to do your exploration, you'll see the cervix there. This is the time you can always do what we call post-placental intrauterine device insertion, if you had prepared the client earlier. Because you will have also, we have the Kelly's forceps, you can clip and then so that's all. So when you're doing a VE, you must make sure you go round, no cervix. But this one is always very naughty, the anterior one. So if you're not careful, and you know when a cervical tear, it can bleed. Bleed a lot. And remember the 40s for the PPH. We are familiar with them. Okay.
Midwife attacked.
Thank you.
That's a whole lesson. So basically, she has shown us that you can successfully use this task trainer to train your students, and talked about perineal repair. We have the perineal repair here. These two models. The assumption is you'd have a high table or your delivery table, and then you clip it on that delivery table. Then the students learn how to do their suturing. I'm seeing one was actually sutured. So what I've just done is put it on its ring. And it is written here. So you feed it fluid. Once you're done, you put it back. So when you do your IO, there'll be feedback. So if you put like the simulated blood, because it comes with simulated blood, and you only put 5 mils, not more than that. You put the 5 mils, then as they do the IO practice, there's a realistic feedback, as would a real patient. What else can we do with this baby? You can do CPR, you can do the basic nursing skills. Delivering, drying, stimulation, cord care, you can do with this mannequin. I'm trying to get her clothes out. Lavender. So, baby, oh, that's resuscitant. So this is a baby that also has stomach for stomach care here and has consumables. You can replace this for the doctors for umbilical catheterization. So what they do, they just remove this and put the umbilical cord that has just been cut and has the blood vessels. So they can do catheterization. They can learn how to do umbilical catheterization in the baby. You can do stomach care. You can do urinary catheterization with this one. They train how to get in the right size and how to do the procedure. And basically, you can also do IV. You can simulate pulses. So in the box, it has a squeeze valve that comes with a tubing. We'll put it here.
So that will be your manual pulse. You remember the mid fidelity we were talking about? A little bit of physiologic response like in a real human being. So here you'll be able to get the umbilical pulse with you being the pulse, a manual pulse system, and also the brachial, because it has the pulse points. You can do CPR with this. You know, it's usually 2 finger, 2 thumb, and suckling. So you can do that with this particular mannequin. When you do your bag and valve mask ventilation, they'll be realistic chest tracks. Because remember, you're also intubating it. What we try and avoid for this particular model, since you're not able to get out the stomach, when you're doing your NG, do a dry training. Don't do with fluid, because we cannot access the stomach, this particular one. But here, you can fill with fluid, 5 mils for the lumbar puncture training. You can fill the bone on the limb for IO training as well. Okay. So that's about newborn baby. And also basically how to handle the baby, how to, how to teach on cord care. When you're teaching, when you tell them go around and then on the cord, you know, it's just you say it's different, but when you're teaching them how to apply the, chloride sedation, when you're teaching them, here, when they go and see a baby, they know I'll hold the cord, then I apply round on the cord. Then when I'm doing my diapering, if I choose to do that, I can still do that way. So I'm going the cord like that. They're not applying the diaper the around. Yes. So that's newborn baby. And I advise a ngo yake. Yes? Okay, thank you.
That is the baby one.
You know a baby lover when you see one. Okay. So this one is for training with this front flex. So once you're done doing your maybe cervical dilatation and effacement training, now you want to do the actual delivery. This is the lubricant gel. So you make sure you lubricate the head very well, the whole body, just as a real baby would be. Then you change your perineum back to the other one, from the cervical dilatation one back to the other one, and that is where the skills coordinator comes in. Today you're teaching on normal birthing delivery or the birthing process or the labor process. We do not put the cervical delivery module, we put the actual birthing simulator. So they set for you. So when the students come, you know, tunafanya birthing peke yake. So you can birth with the head, of course. You can birth, breech, and teach on how to deliver a breech. But key thing, lubrication, lubrication, lubrication. That is all. And you use it. So we have an advanced model, which is not this one. But usually we do not know how much pressure we apply on the fetu's head. So this app is able, as the student is doing the birthing, the baby is linked to that app and they're able to see what they're doing. First stage, second stage, how much pressure is being put on the fetus head. You're able to monitor and give them the metrics of that. But this one is not the advanced model. This one is the basic model for birthing, and then it also has its realistic placenta and its umbilical cord. And as I advise, we keep her in her box so that I see confusing newborn baby. Yeah. Which other model do we really possibly want to? This one? Breast. The breast model. Who can do a clinical breast examination? And then you tell us what you feel. Someone who didn't see what we did. You just tell us what you're feeling. Health assessment, any clinical instructor says. Any skills lab. Skills lab, come. Trust me, the problem of having taught students, only when I remember, it's a skills lab. It's a skills lab. We are not judging anyone. No knowledge judging here. We are familiarizing with the mannequin.
What's her name?
Let's go to Anne. I think she was in Anne. Yes. Yes.
So we want to palpate to assess the breasts of the mother to see if there are any abnormalities. So first of all, I'm going to introduce myself to Anne. Hi Anne, my name is Lasinis, and I'm here to assess, to do a physical examination on your breasts. So if you allow me, I will proceed. Then I go wash my hands, dry them, and put on. It's a clean process, clean gloves. So I can do it in 2 ways. I can do it in 2 ways. One, when the patient is lying down. There's self and then there's one that we do it as a physical. Self-breast examination. So for the self-breast examination, that is where the patient stands on the mirror, using a mirror and usually it's looking at the mirror, yeah? And then you'll tell the patient,
As a clinical, yes. As a clinical breast examination.
Clinical breast examination. The way I've seen, we've always done it, we ask the patient to lie down, facing up. So I will ask the patient and secretary to lie down. And then so first of all, you're going to start with the inspection. That's the general inspection, and then you inspect, then you palpate. Not palpation, then inspection. And then, so we're going to inspect the breast. Yes, before laying down, we inspect the breast for symmetry when the patient is standing up. So we look at the normal symmetry of the breast. For me, the way I can see, my lymph
What you can see. That's
There's a principle of what you can see is what you can see. What you're seeing is what you're seeing.
So I've inspected. The left breast looks a bit bigger compared to the right one. So that automatically already tells me that something is not, because normal breast usually is almost the normal size in a normal breast. So and then other than that, the symmetry, I'm going to check if there are any visible laceration or scars or wound. I can't see it. So
Can proceed.
now we proceed. We've already checked the symmetry. Then now we will lie down. When we lie down, we start with one breast at a time. So I will put this is the left hand of the patient above the head, to lie, to unfold it to go under the head of the patient, to the center. Then I'll start with one. Really, imaginary division in 4 quadrants. Then I palpate each quadrant.
without skipping.
Just feeling the and I'll go round. There's a lump. I can feel a lump on the upper quadrant, the inner part of the breast, say covered in 4 sections. So this other side is normal, the axillary one. The axillary region is no lump. And then as it goes circular motion, there's a lump on this side. As you assess the reaction of the mother to stimulate, how you are touching the breast. So you can even ask the mother if she's feeling anything. Then after that, you squeeze the nipple to see if there's any discharge. So already we've noted that. Then you go to the left breast. So you let the mother to straighten. You tell the mother to straighten the left arm, and then now you fold the other one behind the head. So again, we're going to use the same technique. We're going to divide it into 4 quadrants. Then you start palpating gently. There's one that is obvious here, and then there's one that looks, I don't know if it's very structured. 2 lumps.
Maybe second hand. Comes to find, is there any pathology in the breast? Okay. I see the way we are like, you see, at least you know how to put it, but as faculty, when you've put something as to examine, now you let the students find it. So no. Yeah. Yeah. So there are 2 lumps. Thank you. Yes, you did. Now, like in breast examination, this one, remember we're using imaginary, imagination as well, and giving a scenario. So the students need to get into that space of, this is Anne, 24 years old, has come to the clinic. We need to teach the Anne on how to do self-breast examination. But now you want to start with the clinical breast examination. So you're training on communication skills. You're also training on the skill of actually doing the inspection, palpation, and communicating your findings back to the student. So you as faculty, you know where you've put your notes. You might even put in the lymph nodes. You see if they can identify where the lymph nodes are. If they're able to pick out a cyst, if they're able to pick out fibroadenoma, are they able to measure it? Can they demarcate its margins? They were due in a tosha margin. And we call this a task trainer, so it's a task trainer. The nursing skill mannequins, those ones you're conversant with them, right? Gynecological skills, uterine sounding, insertion of IUD. Insertion of your IUD, it has a clear uterus that then you train on sounding, and then insertion of an IUCD, yeah? And then you can do your pelvic, but then remember silicone lubrication, lazima, and then correct insertion of the speculum, how they open it, what are they looking at. So this particular task trainer comes with different pathologies for the cervix. So you can put maybe a cervix that has a carcinoma or a node, you put that, and a normal uterus. And then you can train them on the bimanual examination of the pelvis, still midwives, and also for advanced scopes and gynaes, we can use this for training, because bimanual is from the abdomen and also to the vagina, and of course the measurements of whatever it is you're looking for. So this is basically an gynecologic model, not obstetric, gynecologic model with different sizes of the uterus and different pathologies for the cervix, and also the added ability of putting a suppository. Can you? No, this is not one. But you can do your uterine sounding and train on insertion of an IUD. CLA is a German doll. It took for 24 weeks to be manufactured, and that's why I'm telling you it will give you 15 plus years because of the quality of the material that has been used to make it. So this particular model, I think you've used it, isn't it? Have you? Has anyone used it? Oh, I don't know. I will get my prof because we need to secure the neck. It should not be free like this. It's decapitated.
It's not strapped.
The next screw is in the pro. Yeah, this screw.
Yeah.
I get the screw. It's there. It's in the office. I delivered it. So this is a basic nursing skills mannequin, of course. You can do your head-to-toe assessment, otic care, eye care. The eye can be removed using a spoon, teaspoon. Sure. Yeah, just put a teaspoon. Unaingiza nyuma. So during maintenance of the mannequin, so you scoop out the eye from the eyeball, you spray to the silicone oil, then you just plop it back. Then inarudi tu ndani. Of course, oral care. The teeth can come out as well. Because they are just, yeah. This is magnet. Yeah. So you just put it back and it will attract itself back in. It's back in, both upper and lower. You can do your tracheostomy care. So if you have the tracheostomy, you can insert and then train on how to give tracheostomy care and also suctioning.
That comes out.
Yes, this one comes out. Just have the wrong nails for the day.
If it comes out, it comes out.
Yeah, I have the wrong nails for the day. So here, who removed the lungs? So someone did surgery, lobectomy. So these are the simulated lungs. So we just put the left and right. Just a simple insertion, left and right. The student alifanya what they do best. Pull it out. Yeah.
Such like nilikuwa unasema inakosa kawaida.
Yeah. Then it has a stomach.
Yes, come on, is there.
Isn't it? No, I'm trying to see if it isn't.
The lung ilitolewa.
There's some fluidish. But you can unscrew it. So you just unscrew the stomach, rinse, let it dry, screw it back. So it's just a screw mechanism. So you screw it back and put it back. There's isn't it? Yes, fluid. Maybe you select it. Maybe it's a silicone. There is. See. Someone put some water in it, someone probed it. Anyway, it's okay. So you can do your nasal gastric and do your feeding. So here you can do the actual feeding because it has a stomach that can be unscrewed. You rinse whatever, you let it dry, then you just screw it back. But whenever you're screwing it back, you remember here, there's the silicone. Silicone spray on silicone spray, it's okay. So once you're screwing it back, you can either spray just a bit, moja, alafu you let it spread around the nozzle, then you just screw it back. Or you can use the Vaseline. This is talcum, sorry. You can use the Vaseline, this one. It's kawaida to Vaseline. So put on the lip of the mannequin, and you put also around those tubings, and then you just screw it back. So the talcum, I'm already feeling some stickiness some places. Maybe the person in charge of the skills lab will just do water and soft kitamba, wipe it, kabisa the way we would do a head to toe, cleaning of a real patient. Of course, don't splash water. So just wipe it, and then after it dries by itself, then you use the talcum. You just do this. Yeah, you just pat the talcum, wipe it down so that stickiness disappears. Yeah. So this is the IV. You ever put here? So that's IV. So here, because of this stickiness, we'll do liquid soap and just a bit of warm water to remove the glue. This one. That's the strapping glue. So just wipe that one down. After it is nicely dry, you pat it with the talcum powder. So here, this is your reservoir for the IV system. So you put whether it's water or whatever you open here, then you let it run through mpaka hapo to turn the air. Then you use it for training your IV. So there's the IV insertion of cannula, how to start an IV, because it will go into this reservoir. Once you're done, you empty it and you put it back. So it's a basic, so everything about it is a basic, very easy to use kind of mannequin. Yeah. So then we have here the intestines, and then we have the blood. No, you just pull it out in a top. You see this screws up here? So this is where you do either your silicone spray, kidogo, or your Vaseline. And then you just put it back shut. Then we have the bladder, which you can fill with urine. Similarly, you can put water in the urine, in the bladder, and then you do your insertion of a catheter, and there'll be feedback of backflow of urine. So this is a male, this is a female. Just the way it is. So on the inside parts, maybe there's this one. So this is what you pull out, like that. Once you've removed it, then you disconnect here. The whole thing
You can still go on the other side.
So you want to make your mannequin a lady. So here, itaingia huku nyuma. So you just change. You look for the same thing.
Wanaingiza.
Plus it has a uterus. So of course you put your hand through. Get it in. And you'll touch it, it feels mafuta, because when I delivered it, I had to do the initial kupaka mafuta so that it doesn't crack. So you secure the back part, then you look for the front part, but it's still out. That's this one, inside. So this is what should secure it. This is the filter. So this one secures it here. And this one secures it. That, then you connect. This here. That way. And you have a female. Do your catheterization. If you have a wig, unazambalisha. Kuongeza realism. Unazambalisha wig. So that it's female. Yeah. The mannequin has a strong look. So the places that require the silicone spray, places come up because they're articulating places. No, it's okay. If you put your hand through, you feel it has the silicone spray because it's an articulating joint. Every 4 to 6 months you have to keep spraying it so that it doesn't tear. So then these are the injection pads, and it also has some on the back. So basically that's it. You remember the joints I was talking about, periodic spraying? This one. So you spray here, do that. Spray here, do this. Do that. Remember this one? It can do this, but not beyond. It can only go up to a certain point. So you don't force it beyond its point of, we call this adduction. Yes. Then it can also come to the outside up to a certain point and then back. So it gives the realistic, so that one can't. It can put its hands to the back. So it has the limbs, remember, it can also bend its legs. So when you're teaching on patient turning and all that, you're able to manipulate the mannequin. If it's a female, you remember when I was saying insertion of catheter? You do not go all out, no? It's up to, because this is what an actual human being would do. Then, so of course you're right somewhere here. So you also treat the mannequin the same way you would treat a human being. Okay? So that is it about this mannequin, very basic, nothing much to it. And it's the basic because that is the starting point for all the nursing training. So now we leave it as a female. The male bit can take a break for a bit. Yes. Yes? Okay. Yeah, we can become female for a bit. Yeah? No, that's the ostomy, the colostomy part. So if you want to teach on colostomy, you just replace this abdomen. Put this one here. Stomach, yeah. Then you put it here. Yeah. So just replace. That's the catheter. So this one, when you want to lubricate the tubing inside, you use your catheters. This one. So you just spray on this, then you do the probing, call it probing. So you probe the urethra so that when you're doing your catheter, it's not getting stuck. Yeah. Very important, this one, very, very important, the manual. That's why it has to stay with the box, because this is where you get to know the part numbers, how to do what. During maintenance, this is what the biomed will utilize to know which parts need to be done, what, because it's clearly written. Checklist, maintenance for talcum. Checklist, maintenance for Vaseline, and also checklist for the silicone spray. It's all clearly indicated here. I think that's it. Any question about the door? Yes, because you already put simulated urine. For you to secure the catheter, so you have to put as per the volume indicated in the catheter, and then it won't come out. But then you'll have the realistic backflow of urine, which tells you you're in the bladder. Yes.
The other time when you were trying to use this, like who was saying, Elizabeth, you found a student who was ready to break
The model.
I think we have just to be careful on this kind of things.
So maybe you need to give them orientation as well. That this is a task
The
training.
line.
And this is the IV. So utilize the IV site. Because still it is not a human being, it is a mannequin. Yeah. So, because here they just need to train. Basically, how do I hold my granula when I'm going in? There's
With the
this is
drawing.
not for me, but there's a doctor, alikuwa na a patient. Tourniquet vizuri. But now
Okay. But you face the patient. How was it to
that is
flow?
not funny. So you know you just come in, not on a mannequin, a patient, a patient.
Really?
A patient, yes. A patient. True story. So help me God. So help me
No,
God.
it's possible.
Yes. I've been in Kenya for a bit.
Yeah.
Yeah, for a bit.
He's checking our patients.
You're blocking our
Blocking the
breathing.
road.
Yeah, so that's about the nursing though. But yes, skills is very important because you see now you'll not jump. Of course, you'll stop her pole pole with a castori so that you tell her, and finally, this is how we do it. But and they appreciate That's the one thing I appreciate. Nurses, we do a lot, and we know a lot. We just need to talk.
We are the advocates of the
Sure.
Exactly.
So when we see things not going right,
Yeah.
we have the obligation to tell the doctor that happened. You need to do it this way.
Yeah. Or even just make a joke of it. You won't go, dog. So they'll stop like, what was that? No, so, but it was a new student, so you can't really blame them. It's their first experience, so you cannot. First experience, yes. No. Students. Med school, not intern. No, med school students. You see, they go for rotations. They're like, I want to try putting up a branding.
But even the anatomy we did fluent.
It's another to apply.
What I'm saying, you are not blaming doctors only. Even nurses don't know.
Yes.
Like when we want to check the brachial, they don't know. They were BSN so could go everywhere. But now you don't blame them. You just show them the anatomy and they get it right. Yeah.
Yeah, so it's
possible.
It's down to skills, and that's why the skills lab excites me.
Exactly.
Because you get it wrong here. You get it wrong until you get it right.
That was the patient.
So maybe we'll do the last two because they're more or less the same. We need, yes, we do need a baby cot. Someone made a Chinese out of the model. So, this is Risasi Ann. This is not Risasi Ann. Risasi Baby. This is Risasi Ann. Then Risasi Junior. So any mannequin, Risasi or little baby QCPR, it's an BLS model. So training on chest compressions and ventilations. But now for the full body, you just incorporate positioning. Because most of the time they usually use the half bodies, the torsos. But this being a whole, you can also use it for nursing skill, but there's not really much you can do with it because it's basically a BLS. It's a BLS model. We also have a Risasi Ann with an airway head, which now converts it to SELS, because now you can use airway adjuncts. For this one, you cannot do an airway adjunct, but you can just do a bag and valve mask. The baby also, same thing, resuscitation. So all these models, they have an incorporated Bluetooth connectivity. So you can charge them, or use a battery. Then when you're doing your CPR, you use your app to watch the metrics. Most of these manufacturers have gone to utilization of technology, application, the apps. This one works on any, see iOS, like limbs and things. This one works on any. You can download the Lidl app on your phone, Android, I have it on my Android phone. And then when the students are doing the CPR, they're able to see.
Labda ni hiyo. Jaribu. Maybe it has
It has the battery already. It's not. Gongo. So BLS, chest compressions, and then this one comes with the different chest coils. So you can make it to be like for an obese patient. An obese patient plus maybe our chest compressions are totally different. So you can make it, you can increase the level of difficulty by having a tougher chest, so that it gives them that realistic feel. Not all patients are the same. So for you to achieve is it a third anterior posterior diameter when you're doing your CPR? 2/3 or a third? 2/3, yes. To achieve the 2/3, how much force should you use? The other thing, this mannequin cannot be used on a bed unless you go on top of the bed. Yes, so it has to be on the floor. Yeah. But if your scenario is for a real patient, then the student has to get on top of the bed to do the right way. So you're supposed to lock and you're over your arm completely. This one is not CPR. This is wrong. We cannot train them like that. They have to be over their arm this way, and it is locked and then like that. Yeah. For a child, it would be easy. You can do, but okay. I did peds, but we don't do this. because we get tired. Two thumb encircling method so that you're able to achieve the required diameters. So with these mannequins, you can choose to use it as a nursing skills, but its role is BLS, chest compressions and correct ventilation and positioning of the patient once they are back. The same applies for the resusci junior. So still the same care needs to be applied. Soft cloth, liquid soap, water, we clean them up, then we can always just cover them completely so that they don't get dust. Is there anything else remaining? There are basic models like the for babies.
Just because you may get tired and you compromise. You can use it, but you will get tired, you will
We were
compromise.
told that it depends on the number of rescuers.
Then my
Rescuers.
rescuers. But then
If
my
you're
question
two-
would be,
If you're two, then now you go this. But if you want to skewer you, use the middle finger and index finger.
then the question comes to how effective are your chest compressions? Because we need to understand the science behind why you doing chest compressions.
And
You're trying to get blood out of the heart, which it should ideally be by itself. So that compression is supposed to maintain circulation. And to maintain that circulation, you need to maintain that the required depth for you to achieve that consistent circulation, because the aim here, we want to return to spontaneous circulation. If the heart does not get blood, they'll not be returned to spontaneous circulation. So it has to be effective. Your compressions have to be effective. And because of fatigue,
Because this one you will rarely get tired.
because you're using
You have a
Now,
support.
the reasoning comes in that cardiac arrest can occur anytime. It could be the patient alone when health personnel arrives. So as you wait for help, there is that mechanism for one rescue and there's that for two rescuers. Yeah.
So the mechanism for one rescue does what? By the way, what takes priority? Just compressions or ventilation?
Ventilation.
Ventilation.
Think again. Think again.
Yeah, but
If there is
it
no
depends.
circulation,
Time may
So,
matter.
Yeah.
And so there is a time.
yeah.
You will end up there because it's better than not
Yeah.
doing it. Because you are alone.
Because compressions,
It is there.
ventilations take.
Yeah, that's it.
for a baby, it's ventilation. But for an
Because you
adult,
only start compressions when the heart rate is less than
CMP.
60. That's when you move to the compression. So ventilations is
It
more.
also depends
So it's
on
patient
your
dependent.
assessment.
Yeah, it depends on the age of the patient. Yeah.
But then that would bring us towards the latest algorithm. Yo, it's need to go back
like
and
this.
read.
For an adult, you prioritize chest compression and circulation. For a baby, you prioritize respiration.
You must go the
In
structured
adults,
way.
prioritizing chest compressions because the cardiac arrest is predominantly from the heart. In children, it's respiratory.
That is normally a
Yes,
problem.
that's the first
Yeah, an assumption.
Yeah.
So it takes you to the activity.
So at least when you understand why is this on a priority, then you'll also tell the students by the way, if it's an adult, it's predominantly a cardiac thing. So prioritize your chest compression. If it's a child, starts respiratory. Because they give us time. Babies, the good thing about them, they will give you time to intervene. Yeah. If you don't, now it is downhill and there's never coming back. Yeah. By the time a baby arrests, we're in problems. Yeah.
I've seen the camera.
I've forgiven that person. So where we have a little bit of not obviously visible lines at the higher fidelity mannequins. And even this baby, the newborn baby also has lines, but they're not visible like this. But once you feel the blood system, then you have to like palpate to feel where
Actually, the idea or the ideal is to put in the imagination of this person. Number one, they are training the hand to get there. When the hand gets there with the needle, when a prick has been made, how does it feel? You know there is a feel that you are having, that is given. Again, that is what is being given to the student to have that feel. You know, it cannot be so natural. But you have these two feels. When you are holding the needle, how do you hold it? And when you break the skin and there are those two differences. So that is what you want to put in this person. So that when they are now in reality, they are able to tell. Because the natural you can't know. So it's those two techniques that you really want to give them a feel of.
And also what is being incorporated is the backflow. See, because when you insert a cannula, there's usually that blood, that backflow that comes that tells you, okay, you're in the vessel, stop. So don't advance the needle. You pull
The
back.
metal.
Yeah, don't advance the metal itself. So, you know, pushing the cannula itself, then, you know, secure it. So the task trainers are now incorporating that. That's where there's this simulated blood. So that when you're in, you know. So that when they go to a patient, they will know. When I am in and I see that backflow, I know I'm in. I stop advancing my needle even further because it will puncture through and through. Yeah. Yeah. Okay.
I wanted to ask, for the IUCD insertion, do you have the transparent models whereby you're able to see how far you are going?
Yes. So I think there's the condom model already. It has a transparent. And also that one, there's a transparent uterus in the box as one of the. So this one, it has a transparent, one of the transparent uterus. So as you're doing the insertion, you can see the UCD. But also, that model has a transparent uterus. So you just change the uterus that is there, you put the transparent one. And the application is easy, it's a screw. Apply a screw, then it's secure. So long as you just put your pelvis holding, then you put your cervix, and then you put your uterus, and then you just screw it like this. Then you're able to train on the sounding, and then insertion of the IUCD, and they're able to see on the inside how it looks like, how it positions itself. Yeah. But this is more of a condom model, but it also has that added unless it's a like middle insertion, cannulation, that one you can do. But anything that requires cutting and it is not a surgical, it's not a suturing model, then don't do cutting procedures unless you have known the suturing models. And that is why, like this one, you don't cut, it's already a pre-cut. This is mediolateral, this is midline, so it's just a suturing, and then you will doing your check so that you've not sutured the anus as well. Okay? But you have suturing models that you can do the cutting, suture, cut it again, suture it back, cut it. Yeah. Because that's what it is supposed to do. Yeah. So for the newborn baby, the way I had said, since we are not able to access the stomach, so we do a dry NG. We don't do an actual feed because now you'll not be able to get it out. And you see moisture, silicone, if it is not properly dried, mold. So you want to avoid it starting to mold. So that is part of the care that we were talking about. What are the procedures you think that you want to do in a real patient? For the IMs, we recommend a dry IM. Of course, they know how to draw the drug. That's a secondary training, how to draw the medicine, how to remove the bubbles, how to pinch and inject. But now, since these are, the inside part is more of foam. It's foam. You don't want it wet if you're not able to dry it. If you want to do a wet procedure, then be sure to remove the foam from the inside so that it's dry completely. Then you put talcum powder and put it back. But it has to dry completely just to avoid molding. Yeah. Remember the back of our mind, these are mannequins, these are task trainers, and not human beings. They are teaching clinics. Any other question? I hope you learned something from the session. Yes? You learned how much. So can I simply call this session 1? We can really plan for another session to go in depth into the system once we get the link reattached. We get it reattached, then we can go further into the market reality. That's okay with you. Then I owe you feedback on I sent the school for the the school. Do you remember the next school for this one? I think it should be the office. Because I need to send you out. So but it's easy, just like the head and British at the same time. For the same level. There have been no questions, or maybe questions later to follow an email. Thank you so much for your time. I really, really appreciate you've been planning this for a while. A very long time since I made the first and the second delivery. But I'm very grateful for the partnership with Uzima. Very, very grateful. And I hope to still be there to walk you through, even as you go into advanced levels of training. Praying it goes through, you'll have gone into another level of simulation altogether. And also just see how to capacity build your skills instructors on methodologies of running the skills up. That one I will communicate when we manage to get an opening or two with our partners for training. I will communicate, maybe get one person maybe every 6 months or depending on the available slots for training. But of course we'll prioritize Uzima. Yeah, being fast. Thank you so much. Thank you so much.
Thank you very much, students, for having taken your time to come and take us through. This is actually very important for us because skills is very important in nursing, and that is what makes nursing. Without skills, there is no nursing, and it should be properly done to ensure safety. And that is also what will instill confidence in our patients. And I say that if we give the students quality skills, the students will also feel good about themselves. And just as we had talked yesterday about the different learning styles, so let us also begin to appreciate our students. Everybody is not the same. And then how do we take them through this journey? Because I always tell my students, before you came here, we did not know you. You are the one who applied. You wanted to come and do this course. So help us to help you to reach where you want to go. So in that kind of situation, what makes the student not feel like doing what they want to do? And it all begins, and that is why I say the clinical instructor is a very important person in the student's life. Because it all begins from there. Theory and theory, yes. The student is able to digest the theory. But with clinical instruction now, the student is actually expected to do what they have learned. So what we should enhance is what facilitates this. So we should ensure that conducive environment and supported environment, which starts by in fact, as I was sitting here, David was telling me, hey, the demonstration is very good. If we can continue doing it like this, the students would not want to leave the skills. But I'm sure we have seen this of late. Our students don't want to leave the skills. They want to come. As initially before, they would try to evade. But right now they feel very enthusiastic. So we are very, very grateful. And we are going to continue to collaborate because we still want more. I don't know if you have the videos of different and where we can get, maybe if you could advise us where we could get the videos for different procedures.
So that should be limbs and things. There's they call it hints and things. So they show you how to do some procedures, but I can also just collect some videos.
Yes.
Like I used to use the RNAs. For those who are a bit into tech, there's the RNAs who does short videos on procedures.
Yeah, and we have an RNAs who works in collaboration with the RNAs.
Yes, so there should be some videos of RNAs.
So I think because it's very good, actually now it's going to form part of it. Especially we are bringing him in for scenario and case study development. Yes. Yeah, so Regina has been there twice. And
Regina Kinanas?
Yes, and I think she's also come back. Okay. So he has been part of the program.
Skills is big. I know skills is big for NNS.
Yeah. So I think we shall to make our nurses feel good about themselves. You know, if you satisfy a patient, there's nothing I used to feel good as the patient appreciating you. You feel so good and you look forward to the next day. Yeah? And that is all that we are looking for. Other things will come. But once the patient appreciates and gives a feedback, it makes you a day and it helps you to improve. And that is what we want for ourselves. So I think our collaboration will continue. Yes, and we shall continue conducting and traveling.
No. Uzima for me is home. I think when you were at Jotiaret at some point, you must have taught me in bedside in 2012. Because I remember it. So it's, if there's anything very interesting about nursing is, you know, you go and come back and it's about the impact. So for me, Uzima is home for me. So yes, I'm very honored.
So thank you. Karibu tena.
Asante. Put them back together, the specific boxes, and then maybe the key person who will be in charge of them, we can.
Yeah, we should be working closely with Celine as usual. She's actually the coordinator.
Yeah. Okay.
And I think you have to.
A lot. Yes. A lot.